Welcome to a very special edition of OncLiveOnAir. I'm your host today, Jessica Hergert. OncLiveOnAir is a podcast from OncLive, which provides oncology professionals with the resources and information they need to provide the best patient care. In both digital and print formats, OncLive covers every angle of oncology practice, from new technology to treatment advances to important regulatory decisions. Today, we had the pleasure of speaking with Shiraj Sen, MD, PhD, and Roman Groisberg, MD, to discuss key takeaways from the 2020 ASCO Virtual Scientific Program on exciting efforts being made in the field of sarcoma. In our exclusive interview, Dr. Sen, Associate Director of Drug Development at Sarah Cannon Research Institute, and Dr. Groisberg, a Medical Director at Rutgers Cancer Institute, highlighted research evaluating checkpoint inhibitors and combination chemotherapy regimens in the evolving sarcoma treatment paradigm.
Hi, I'm Dr. Roman Groisberg from the Rutgers Cancer Institute of New Jersey, and today we're going to talk about some of the latest developments in sarcomas coming from ASCO 2020.
And hi, I'm Shiraj Sen. I'm a medical oncologist and clinical trialist at the Sarah Cannon Research Institute at Health One in Denver, Colorado, with a focus in sarcomas. And I look forward to discussing these abstracts with you, Roman. So Roman, why don't we get started with abstract number 11505. I thought this was one of the most exciting abstracts presented this ASCO 2020 in the sarcoma section for a couple of reasons. So to me, it really focused on some key features that we're beginning to understand in sarcomas, namely how subtype-specific responses are likely to be with different types of therapies, specifically immunotherapy versus chemotherapy versus other novel therapeutics that were presented here and with trials that are ongoing, but also exploring the role of perioperative therapy and how we might be able to start moving some of these drugs, like ones discussed here with nivolumab and ipilimumab, into the perioperative setting, even though we don't have FDA approvals of these drugs in the metastatic setting. So this was a trial for everyone. This was the preliminary results of the phase 2 study of neoadjuvant checkpoint blockade for surgically resectable undifferentiated pleomorphic sarcomas and dedifferentiated liposarcomas. Many people already know that beginning with the SARC-028 trial studying pembrolizumab across soft tissue sarcomas, that those were the two soft tissue sarcoma subtypes where we really began to see some efficacious results with pembrolizumab and subsequently in studies we'll talk about here with other checkpoint inhibitors. And the MD Anderson group here had a very provocative study design with some really interesting biomarkers that they're looking at studying neoadjuvant Nivo or Ipi-Nivo in D-diff liposarcoma, as well as neoadjuvant Nivo with or without radiation and or ipilimumab for undifferentiated pleomorphic sarcomas. Here, the primary objective was to look at pathologic response as a primary objective in all of these cohorts, with secondary objectives of response rate, recurrence-free survival, safety, and patient-reported outcomes. Roman, any initial thoughts on that?
The study design is neat because it really gives you a window into how these drugs are working and really looking at what's happening at the tumor level rather than on a radiographic level like we usually do for these kinds of studies.
I totally agree, and I thought pathologic response was a neat endpoint, and Dr. Rowland did a great job of going into how they assess that. This is a tumor type where it's not standard to know how to assess pathologic response with checkpoint inhibitor therapies, and she did a great job discussing some of the prognostic significance of necrosis and how that's controversial. And I thought it was neat that they looked at hyalinization and or fibrosis as that pathologic response criteria. And again, the data I thought also bore that out, which we'll go over in a second. What I thought was, again, great was, they demonstrated in this trial that it was not only feasible, but that a fair proportion of patients completed the pre-op therapy. 100% completed the Nivo and the D-diff liposarcoma cohort, and similarly across the different cohorts that the majority of patients were able to complete therapy. There weren't too many AEs, not ones that are at least unexpected. And again, most patients made it to surgery. Looking at then the pathologic response, there was, dramatic response in the undifferentiated pleomorphic sarcoma subgroup, as well as, again, showing median hyalization of 93% in those patients. Much less, which I thought was interesting, in the D. diff liposarcoma, with median hyalization of only 8.75%. Any thoughts on that?
Yeah, I actually think that may be due to the inclusion of radiation for the undifferentiated sarcomas arms, because the D. diff lipos did not get neoadjuvant radiation. There was some radiation included in the UPS arms, so that may be a kind of a differentiator there, explaining some of the difference.
That's a great point. And it'll be interesting to see through other studies, how radiation impacts hyalization across various sarcoma subtypes as well. Going into then the minimal residual viable tumor that was remaining, in patients, I thought it was pretty eye-opening. I don't know if I expected this, that there was only 5% residual viable tumor as an average across these patients. And of course, with a much higher residual viable tumor of 77.5% in the D. diff liposarcomas.
I wonder if we're talking about some synergy between the radiation and the checkpoint inhibitor, because that's been an idea that's been tossed around, certainly with the abscopal effect, but with a lot of other publications, that there's potentiation of the radiation by nivolumab and vice versa with the release of neoantigens. So I wonder if that's a part of the story here.
Yeah, I totally agree. And it'll again be neat to see in other soft tissue sarcoma subtypes if the data is replicated, or if this ends up being a UPS specific phenomenon.
Well, UPS is certainly the standout in as we kind of continue to talk about some of the other immunotherapy studies.
Yeah, I agree. I think that's one of the things we're learning is this is essentially may really be a sarcoma subtype specific phenomenon we're seeing. Looking ahead to some of the other abstracts, I think what's neat is despite similar drugs being used, these trials are enrolling different patient populations, right? There's going to be other trials that will enroll, chordoma with a great response and other uncommon sarcoma subtypes. And I think as we collect more data, it's going to be really interesting to see where the largest impact is. But looking ahead then to RECIST, right? They also looked at RECIST responses. And here, there was only 2 RECIST responses that were seen. And while there were some other patients that had tumor shrinkage, they were technically stable disease for RECIST. And then, of course, a number of patients whose tumors grew radiographically on therapy. And again, what I thought was fascinating was, again, they showed that really this means that in this study and with these checkpoint inhibitors, there was not correlation between RECIST radiographic response and pathologic response. We've started seeing that in some other tumor types too, right? There's data in melanoma, in HCC, and I believe even in non-small cell lung cancer now, where we're getting to see this and really raising these questions of, the value of radiographic response in the perioperative setting.
So true in the metastatic setting, right? I mean, we've seen this time and again where we have, overall survival advantages in immunotherapies without a significant response rate. So it's certainly a story that we've seen before.
Again, I commend the investigators on this trial because I think what makes it challenging is as you're running these trials in real time, and you get these responses, it's got to make decisions on the spot on that relate to surgery and kind of, and these are patients in the curative setting, right? So the stakes are really pretty high here on kind of what's being done and implications of it. But again, of course, the arguably most important results here, right? What were the patient outcomes in terms of time to recurrence and survival? And again, median follow-up, albeit only about 14 months in the D. diff liposarcoma group and 16 months in the UPS group, but the results so far look overall promising with low kind of rates of recurrence thus far. And I think that's why Dr. Rowland very appropriately concluded that that this combination was safe. There were no unexpected toxicities that we don't already know about with checkpoint inhibitors with or without radiation. That again, in UPS, there was a very high hyalinization. Again, as you very well pointed out, the role of radiation in that is still to be teased out. And again, she demonstrated that really RECIST imaging did not correlate with pathologic response. And, I think a lot of the correlative work that they did, or that's still ongoing, will really help us determine and better understand what's happening with these therapies. Any other thoughts on this?
No, I agree. This was probably one of the most interesting studies presented at ASCO in the sarcoma space this year. Interesting not only from a clinical perspective, but the basic correlates that were done. All very interesting, well-designed study. I really commend the investigators on this one.
Absolutely. I do too. I thought it was a great study, well-designed, well thought out. Again, results very intriguing. I really look forward to getting longer-term follow-up data from that, as well as seeing the biomarker data. Roman, do you want to talk about the next study that was similar, meaning similar drug?
Yep, so 11511 is a multi-center phase 2 study of Nivo plus minus IPI for metastatic sarcoma. It's the Alliance A091401 study. And these are results from some expansion cohorts that are being presented. And in this study, they basically report the efficacy of nivolumab and nivolumab plus ipilimumab in each of 3 different expansion cohorts. And those 3 were GS3 gastrointestinal stromal tumors, undifferentiated sarcomas, and dedifferentiated liposarcomas. So the UPS and the DDIF lipos, same ones as we had just discussed. And here they report kind of high level that neither nivolumab nor nivolumab plus ipilimumab had any confirmed response in GIST patients. But more interestingly, in DDIF liposarcomas and undifferentiated sarcomas, the primary response endpoint was met with the Nivo plus IPI arm, but not with Nivo alone, which is something that we've seen whisperings about in the sarcoma community for a little while now, that single-agent PD-1 may not have much efficacy, but the combination is maybe worth exploring further. Now, the responses are fairly modest. For the nivolumab plus ipilimumab combination, response rate between DDIFs and UPSs was 14% versus 7% nivolumab alone. But it kind of broke down by the different tumor types. So the undifferentiated sarcoma response rate for nivolumab and ipilimumab was 28.6%, which is pretty substantial. And the liposarcoma cohort, it was 14.3%. What I will tell you about the liposarcoma cohort is that they included all grades of liposarcomas, including 13.8% were grade 1 tumors. Any thoughts on any of this so far, Shiraj?
I think the benchmark, right, was set with SARC-028 in some of these cohorts when they just, again, looked at single agent Pembro. And, I think one of the questions I came away when I, looked at the results of this trial of Ipi-Nivo was, I don't know if the response, and again, these are relatively small numbers, and even within UPS, there's heterogeneity. There can be some that are more indolent, some that are more aggressive. And again, there have been some really fascinating publications that I feel like have come out even just this year. There's that Nature paper that came out looking at biomarkers associated with SARC-082 trial that were associated with response and or resistance. Looking at these different phenotypes of immune low, immune high, et cetera, tumors. And with all that being said, I have a hard time coming to a conclusion of whether Ipi-Nivo and this 28.6% response rate is really going to end up being better than just single agent checkpoint inhibitor. I mean, I know here in this study with Nivo is only a 7.7% response rate, but again with Pembro in that study they reported 20% ultimately a response rate. Granted, I think because these numbers are still pretty small, right? 13 and 14 patients here, and even on the other checkpoint inhibitor studies, we're still looking at like 20 to 30 patients. I wonder if, as the data accumulate over the years, if dual checkpoint inhibitor therapy is ultimately going to be better than monotherapy, and as the data mature, again looking at survival, which combinations are going to be better than others. Looking at this, abstract just alone, and taking away the other data that we were aware of, this one does argue that dual checkpoint inhibitor therapy in UPS appears to have more responses. It's again very reassuring looking at the spider plot how durable these responses are. So yeah, I mean that's that's kind of my main takeaway and the way I interpret the UPS cohort. And I totally agree with you on the LPS cohort.
I think that, maybe what we're seeing is we shouldn't be really looking at response rates based on what Dr. Rowland showed us in the previous study. And maybe we should be looking at these spider plots and looking at time, at overall survival time, right? Where, in this study, it actually wasn't reached for the nivo plus ipi arm in the UPS cohort. So there may be something to this. And I think as the data accumulates, we may find that the combination of checkpoints is actually active and valuable in UPS specifically. But what this really reminds me of is looking at old data on doxorubicin over the years from the many, many studies that were done in sarcomas. And you see that response rates are kind of all over the place. And so we'll probably find as we go forward doing checkpoint inhibitor studies in sarcomas that we're going to get wildly different response rates as we go along. So it'll be interesting to look back 10 years from now and see how things kind of shake up. One question I had with this study is for the GIST cohort, they reported that the number of lines of therapy that the GIST patients had. So only about 46% of the patients that got nivo plus ipi got more than 3 or more lines of therapy. So what's interesting to me is, how these patients are being put on these immunotherapy trials when they haven't even received all of the kind of approved TKIs that are active in GIST. So I thought that was interesting, and I'd love to sort of be a fly on the wall in some of those discussions. This is a very thought-provoking study indeed. I would say that for the liposarcoma cohort, the results may have been even better if they kind of were more selective about what grades of histology they included, because they did include 13.8% were grade 1 tumors. So those are, we know that those are not chemo responsive, and who knows how responsive they are to immunotherapy as well. But we can move on from here, and we'll talk about abstract 11509, which is the phase 2 multi-arm study of durva and tremi for advanced and metastatic sarcomas. So again, a similar study. Durva and tremi, of course, are a similar combination to nivolumab and ipilimumab. And this study, they enrolled based on subtype. They included LPS, liposarcomas, leiomyosarcomas, angiosarcomas, undifferentiated sarcomas, synovials, osteos, alveolar soft part chordomas, and then they had an other sarcoma category. Enrolled 57 patients total, and their primary endpoint was progression-free survival at 12 weeks. Their median overall survival for all patients was 20.8 weeks, with a 12-month survival of 63% and a 24-month survival of 45%. Again, it's hard to interpret these numbers because they had such a wide variety of different sarcoma subtypes. The 12-week progression-free survival was the lowest for the liposarcoma cohort at 16%, and the highest for the alveolar soft part sarcoma cohort at 90%. Partial responses were observed in alveolar soft part sarcomas, chordomas, undifferentiated sarcomas, and cutaneous angiosarcomas. The adverse event rate greater than grade 3 or higher was 24.6%. And they noted that there was a clinical benefit that correlated with tumors with an inflamed phenotype based on 3 major categories of tumor-infiltrating lymphocytes. And so the authors concluded that in addition to the individual histology, the higher TIL immune score can help predict clinical benefit. Shiraj, any thoughts on this study before I get into my thoughts?
So, this was one of the abstracts I was alluding to earlier where, despite us using similar therapies, to take a step back and put this all into context, these are challenging trials to run, and there's so many logistics involved. And these are really patients who often have run out of their, standard of care therapies. And to take a step back and think about it, right, it's pretty incredible. You've got patients who are now having these dramatic 50% or more responses to these investigational therapies after having progressed on likely a number of prior lines of standard therapy. This is one I was talking about earlier where, right, you've got a patient with chordoma with an incredible, right, response is their best response in terms of tumor shrinkage. You're once again seeing a number of alveolar soft part sarcoma patients responding, which, from prior trials of various checkpoint inhibitors, as well as there was that great publication earlier this year looking at the combination of pembrolizumab and axitinib that specifically focused on alveolar soft part sarcomas, showing again a number of responses that were very durable there. Here there's also, if you look, they call it a vascular tumor, but we're beginning to learn a lot of angiosarcomas are having good responses to checkpoint inhibitor-based therapies, more than just the UPS and DDIF liposarcomas that we initially thought were the signals for where these therapies might really benefit. So, again, I think this, for that reason, is another interesting presentation, another, again, comprised of a number of tumor types. It's hard to miss, though, right, the elephant in the room, that the majority of patients don't respond, right? And when I look at the far right of the waterfall plot, right, it still shows us how far we have to go. There's so many patients who, as from baseline to best response, have 100% growth in their tumors, which tells us that there's still a long way to go to better understand if and how checkpoint inhibitor therapies might work and benefit these patients. But I'll let you go on talking about survival and the rest of the results.
This is a study that really kind of gives you a window into other sarcomas that have potential to respond. Of course, the UPS, there was a 1 out of 5 patients responded. So that's kind of developing into a known entity now. Cutaneous angiosarcomas are another signal we see of efficacy with immunotherapy, and there's been other studies that have highlighted this. And checkpoint inhibitors are rapidly moving into frontline preferred for these cutaneous angiosarcomas. Of course, with alveolar self-part sarcomas, the data's been out for a little while now that these are highly sensitive to immune checkpoint inhibitors. And what's interesting here is that there really was no signal of activity from liposarcomas, which is a little bit contrary to the previous study that we discussed. So it's hard to kind of draw conclusions because there were so many different tumor types included here and with such small numbers. But combined with other studies that are being presented at ASCO, as well as the previous publications, there's a very clear signal of activity for undifferentiated sarcomas and cutaneous angiosarcomas, as well as alveolar self-part sarcomas.
We've now talked about 3 different abstracts in 2 different settings, but with similar agents. How do you approach patients that come to you with some of these tumor types, right? UPS, ASPS, angiosarcomas. When they come to you for treatment recommendations and care, at what point do you like to consider them for a checkpoint inhibitor-based trial versus standard of care?
Yeah, there's certain subtypes like an alveolar self-part sarcoma. I would put them on a checkpoint inhibitor up front. I have no problems with that. The same goes for the angiosarcomas. Usually I prefer to do it on a clinical trial, but otherwise, we can get it off label. And then for the other subtypes like undifferentiated pleomorphic sarcomas, I will usually let them fail at least 1 line of standard chemo. So, I have them progress on anadriamycin before I start to offer them checkpoint inhibitor clinical trials. And then there's certain subtypes like synovial sarcomas where I will run through quite a bit of chemo before I get them to checkpoint inhibitors because there's just not a lot of activity that I've seen with synovial sarcomas and checkpoint inhibitors. So I'll cycle through a lot of chemo before I get there. So I kind of keep it histology specific as best I can.
Great. No, I think that's really insightful for everyone listening. And I feel like there's various practice patterns. Our site's a little different here in Denver, where we're mainly a referral site for clinical trials. And so most patients have had standard of care therapies before getting referred into us, but we tend to see everything. We see some patients that are referred in prior to having any cytotoxic chemotherapy. And that's specifically for, again, some of these subtypes you mentioned where there's now considerable data suggesting pretty good efficacy with checkpoint inhibitors. And again, ones where we know that these are sometimes less chemosensitive tumors. But on the other hand, we have some individuals who self-refer themselves after they've had 4, 5, 6 lines of therapy sometimes prior to coming in and seeing us, and then we'll put them on checkpoint inhibitor or other therapies. And then again, we've also been seeing similar responses on trial as has been reported at ASCO this year. So again, it's really interesting to get your perspective on that. But also, I think it'll tie us in to the next abstract that you'd mentioned. We've so far been talking about just checkpoint inhibitor-based therapy, but now getting into some of these combinations of checkpoint inhibitors plus chemo and trying to understand if and where that might have a role. So abstract 11519 was the pilot study evaluating the safety, tolerability, and efficacy of doxorubicin in combination with pembrolizumab for metastatic or unresectable soft tissue sarcomas out of the Levine Cancer Institute. Again, By way of background, SARCO-2 that we've been talking about demonstrated that pembro monotherapy had promising results in certain soft tissue sarcoma subtypes. We've now seen other studies like the Alliance study also look at single agent checkpoint inhibitor therapy and demonstrate some activity in various soft tissue sarcoma subtypes. And this was one of the studies. Again, there have been others. There's actually been another study that was presented last year also looking at pembro plus doxorubicin. But this is another great study looking at that combination to try to better understand which patients this might benefit and how much. So they also had a variety of different soft tissue sarcoma subtypes enroll in it. And I think, like you've been mentioning, that's important to look at is the demographics. Again, 23% of the patients had liposarcomas, 33% had leiomyosarcomas. There was one synovial sarcoma, 3 undifferentiated pleomorphic sarcomas, 30% that had other soft tissue sarcoma subtypes. Again, these were in this trial mostly high grade or grade 3 poorly differentiated sarcomas. That was 60% of the tumors on this study. Again, they also demonstrated, like we'd seen in the prior pembro plus doxorubicin study, that adverse events were largely driven by the doxorubicin. So ones that we're used to seeing when giving standard of care doxorubicin, namely cytopenias, nausea, fatigue, and other GI toxicities that can be seen. So they reported the response rate in their study of about 37%, giving this combination again, I should mention, in the metastatic frontline setting, and reported a median overall survival of 15 months, right? Again, going back to the same theme of, what outcomes should we really be focusing on and which ones really matter? And again, we can get into a side discussion about that. I think that's going to be a common theme across all of these abstracts as we look at novel therapies, either alone or in combination with standard chemo. What is the best outcome to look at? What's the most meaningful outcome to look at? Personally, I think survival, and now as some studies begin looking at quality of life metrics in the metastatic setting. But, we're still learning about, what does response rate mean for that? What kind of surrogate endpoint is that for survival and or pathologic responses? I'll ask you a question, but one thing I think it's worth mentioning here, that they reported a median overall survival of 15 months. The median overall survival of individuals that we see now with metastatic soft tissue sarcomas, is getting better, right? Largely, probably because not just the therapy is getting better and the patients having more lines of therapy, but I think there seems to be a trend of more of these patients being treated at high volume centers, getting multidisciplinary care, having much better supportive care alongside with all these therapeutic options. Looking across survival of just doxorubicin and other therapies, it was interesting that the original studies of doxorubicin plus minus ifosfamide, right? Survival there, compared to the survival there was already a much higher survival reported in the announced study last year, right? In the dox alone arm. In the announced study, the dox alone arm had a median overall survival of 19.7 months. And so how that compares to then this, where there's a median overall survival of 15 months, meaning that the two being around the same ballpark. Again, this being a heterogeneous condition and various tumor types being enrolled, but the survival, not being much better. I think it, in my mind, again, raises the question of how much does pembro add to doxorubicin across the board? What thoughts do you have on that?
That's actually great that you bring this up, because I'm looking at the response rates of this combination, and they are much higher than what you usually see with doxorubicin, right? I mean, you've got a 30% partial response, you got a 1 complete responder. I mean, it's really small numbers, and I think that the small numbers are really what's driving all the aberrancies in the statistics. So, you've got really high response rates, but then your overall survival isn't particularly, impressive. So I wonder if you just are getting lucky with your doxorubicin up front, and maybe the pembro is not adding that much. So that's kind of one thought. But again, it's a really small study, so it's hard to conclude much from it.
I think that's the question that remains from this. Again, I think this study also highlights that there are these tumor types, right, where you're going to get these great responses. And, how do we better understand who these individuals are who are going to benefit from upfront combination checkpoint inhibitor plus chemo versus not, will be what we need to tease out, and or I think the question should also be, in those subtypes, is there a benefit to getting it up front, or would these individuals do just as well if they got frontline doxorubicin and at the time of progression or at the time of toxicity stopping therapy, or when they finish 6 cycles, if they then get second line pembro, are they going to live as long or longer and or with less toxicity than if they got this combination up front?
Right.
But yeah, no, I think let's go on to the next abstract, right? The abstract, you want to talk about 11520?
I love this. This is the SAINT study, results of an expanded phase 2 study using ipilimumab, nivolumab, and trabectedin as first-line treatment for advanced soft tissue sarcomas. Now, I should highlight first is that the dosing is non-standard here. So the IPI is given at 1 milligram per kilogram IV every 12 weeks. The Nivo is given for 3 mg per kg every 2 weeks. And the trabectedin is given at 1.2 mg per meter squared every 3 weeks instead of the standard 1.5. The primary endpoint was objective response rate, and they included 41 patients with a best overall response rate of 19.5% and a disease control rate of 87.8%. Median overall survival was 12.5 months, with a median PFS that was more than 6 months. They had 4 CRs, although they had an asterisk on that because 2 of them were surgical CRs, 5 PRs, 27 with stable disease, and 5 with progressive disease. They saw responses in leiomyosarcomas, liposarcomas, undifferentiated sarcomas, synovial, and clear cell sarcomas, with importantly very low grade 3 adverse events. I thought this seemed like a very well tolerated regimen, mostly because the IPI is being given once every 12 weeks, which I thought is a brilliant move to kind of mitigate the toxicity. Responses were seen in subtypes that are not associated with IO response, so things like leiomyosarcoma and synovial sarcoma. And I'm wondering if that may be a trabectedin effect. My initial thought on looking at this is really intriguing data, that there's probably enough here to take this to kind of a comparison trial versus doxorubicin. I thought this was a fairly impressive result, since the response rate was significantly higher than what you would see from trabectedin alone. Granted, the trabectedin phase 3 study was kind of a later line study, so it's probably not a fair comparison. But still, a 20% response rate is nothing to sneeze at in the world of sarcomas. Do you have any thoughts on this, Shiraj?
I agree. Your point was well taken, right? How much of this is being driven by trabectedin, right? And or how's the longer term follow-up, how's survival going to bear out? Because, I think there is some toxicity to this. What are your thoughts on that?
The survival piece is going to be very important. That'll take some long-term follow-up. I also think that there's probably a very interesting nuance to all this, that subsequent iterations of this can probably include radiation in, because of the recent data about trabectedin in combination with radiation being highly effective. And then also the use of radiation with immune checkpoint inhibitors, like we saw with Dr. Rowland's study that we discussed up front, I think is going to be a very interesting tack on to this study if it gets taken that far. But I do think that the data is a little bit premature here. The overall survival they write is greater than 12 and a half months, but I don't think they have a final number yet. And again, it's all kind of a hodgepodge of sarcoma subtypes, so it's going to be hard to draw conclusions off of this small study. But I'd love to see more from this. I'd love to see this regimen be taken further.
I agree. No, I thought what they did well was both dose and frequency to allow IPI, Nivo, and trabectedin to be given. I was surprised that there wasn't more toxicity. And then when I took a closer look and realized what you pointed out about the changes in dosing, then it made a little bit more sense and how it became more tolerable. And I think that I thought was one of the neatest things about this presentation was, that they thought that they were thoughtful in doing so. But again, I agree with you, right? There were numerous CRs and PRs on this study, despite it being small numbers. And so I think it will be interesting as more data emerges to see how much of this is trabectedin, how much of it is the dual checkpoint inhibitors in some of these sarcoma subtypes that we've been talking about, like pleomorphic sarcomas, and or is there synergy between the 3 and/or, right, there's an abstract we'll talk about, a little bit. We can talk about a little bit later that just combined doxorubicin and trabectedin, right? The LMSO2 study. What combination partner of trabectedin, right, might make it more efficacious? So,
and since we're on the topic of chemotherapies, let's jump into the kind of chemotherapy section of all of this. And I'd like to discuss abstract 11504, which is the randomized phase 2-3 study comparing perioperative adriamycin plus ifosfamide versus gemcitabine plus docetaxel for high-grade sarcomas. This is from the Japanese oncology group study, JCOG. And this study included grade 2 and 3 soft tissue sarcomas with a primary tumor that was deemed to be resectable for curative intent. They received 3 courses pre-op and 2 courses post-op of either chemo regimen. And the primary endpoint in phase 3 part was overall survival. 143 patients were enrolled and included in the efficacy analysis and split pretty evenly, 70 for AI and 73 for gemdosi. The estimated 2-year overall survival was 94.3% in the AI group and 91.6% with a hazard ratio of 2.55, and a estimated 2-year progression-free survival was 81.9% in the AI group and 64% in the gemdosi group. There were no treatment-related deaths in either group, but this study was designed as a non-inferiority study. In that sense, the primary outcome failed because they could not confirm that gemdosi was equivalent to adriamycin. I'll highlight just a couple of nuances to this study. And one of them was that there were more grade 2 tumors in the AI arm. So there were 48 grade 2 tumors and 22 grade 3 tumors in the AI arm versus 37 grade 2s and 36 grade 3s in the gemdosi arm. And we know that above all else, grade is the most important prognostic factor in sarcomas. So the fact that there were more lower grade tumors included in the AI arm probably threw off some of the outcomes. As far as size goes, the AI arm median size was 9 centimeters versus 10.2 for the gemdosi arm. And of course, we know that size is the other big prognostic factor for sarcomas. And so in that sense, the randomization favored AI in terms of prognostic factors. So I didn't think the patients were that well balanced. The response rate was interestingly lower for the AI arm at 8.6% versus 11% for the gemdosi arm, which again may allude to the grading of the tumors, but also might be accounted by there being more liposarcomas in the AI arm than in the gemdosi arm. And liposarcomas, of course, are not a particularly chemosensitive subtype. But it was interesting also that there were more patients that progressed on gemdosi during the neoadjuvant portion, even though those numbers were small. So the great majority of patients did not progress during the neoadjuvant portion of the chemotherapy. And so that kind of also highlights that adriamycin in the right hands is very doable and kind of remains the standard of care for soft tissue sarcomas that are localized at this point. Other thoughts from you?
No, I agree. I think this is, again, a great endeavor to try to better understand that with specific sarcoma subtypes, right, where in the metastatic setting, there's been, some data that's come out that suggested equivalence of gemtax versus AI, and trying to understand if that can be extrapolated into the kind of neoadjuvant or perioperative setting. I think people debate toxicities, and if one, has quote unquote more or less toxicity, I would argue they have different toxicities, and even that can be patient dependent, dependent on kind of supportive care that's provided when giving these therapies. But, I think a lot of people thought that this study might demonstrate non-inferiority. And so I think it was, a very important study to do. Again, commend the authors on this, on this work, because again, these perioperative studies can be so challenging, right? As trialists, right? I think we appreciate that every patient you put on, especially in this type of perioperative setting, there's, so many variables managing, not just the clinical trial portion of it, but, the drugs themselves, the toxicities, management of kind of surgery, that I think was a great study and did, like you said, demonstrate that Gemtex is in fact not inferior to AI.
Right. So I guess we'll continue to do AI in the perioperative setting for the foreseeable future until this study gets repeated and the randomization favors the Gemdosi arm, perhaps. I want to talk about the study that I think I was probably the most excited about, and that's abstract number 11506.
Great. Yeah, no, let's talk about that one. So 11506 was, a single-arm multi-center phase 2 of doxorubicin in combination with trabectedin, given as first-line treatment of patients with metastatic advanced leiomyosarcomas, either uterine leiomyosarcomas or soft tissue leiomyosarcomas. And these were the final results of the LMS02 study. The prelim results had been published previously. Again, I think a couple of things before we discuss that, that we should just keep in the back of our minds. I think there's both definite pros to doing these, single arm phase 2 studies, right? In terms of, and again, what I really like about this is it is looking specifically at leiomyosarcomas, and it did stratify based on location, so uterine versus soft tissue. And again, that helps us better understand the impact of the drugs on one specific subtype and not just generalizing it to all soft tissue sarcomas. And again, because these are still considered a rare cancer, these studies can be tough to accrue to. And these are clearly being done at sites that are high volume centers that see a lot of these. And I think that's the big pro and an advantage of doing this. I think we have to keep in mind that it's challenging, however, to try to compare to historical controls, right? I think people may be tempted to say, okay, well, let me compare to just dox or just trabectedin. The trabectedin studies, again, even the same patient population are patients who are not treated up front, right? These are patients who, if you look at the study that led to the FDA approval of trabectedin, this was, again, in patients who, had to have had a prior anthracycline therapy, but in many cases may have had more lines of therapy than that was compared to dacarbazine. And that's a very different setting than what we're talking about here in the frontline setting. And once again, being given in combination with doxorubicin, which is FDA approved in the frontline setting. So you're essentially taking two drugs that are both approved for leiomyosarcoma that we all use for leiomyosarcoma, and asking the question of, if you give them together, is it going to be better than giving them separately? So, again, that being said, I think the results were, fairly impressive, right? If you just look at the waterfall plot, this is not the typical waterfall plot of most sarcoma studies, right? Even the ones we've already been talking about up until now that either do or don't have doxorubicin included, you generally don't see so many bars going, south of the zero line and seeing so much tumor shrinkage. So I think that's definitely encouraging, right? Uterine leiomyosarcomas, there was an overall response rate of 59.6%. Soft tissue leiomyosarcomas had an overall response rate of 39.3% with this combination. Again, patients were allowed to get surgery if there was residual disease, and I think that was a point that they highlighted and that the investigators went into, I think, very appropriately in this long-term follow-up study. It's impressive that that we've got now 7-year updated data, and the fact that close to 30% of metastatic uterine and more than 20% of the soft tissue leiomyosarcoma patients are still alive at 7 years. They demonstrate again that the median overall survival across this population was 34.4 months. Pretty impressive number. Soft tissue leiomyosarcomas tended to have an improved median overall survival when looking at the two different subgroups. But what I thought was the neatest was when they then even showed us data on stratifying by patients who went to surgery versus those who didn't. Granted, this is small numbers, right? Now by the end of the follow-up period, you've only got a handful of individuals on both sides who made it to surgery. But these patients have a very kind of impressive tail to the survival curve, right? And again, questioning of, are these patients truly in remission, right? Years out after their diagnosis. So again, I would love to get your thoughts on all this.
Yeah, I thought this study was really exciting. I think this has the potential to be practice changing. But I've been using doxorubicin in combination with another agent, that'd be dacarbazine, for leiomyosarcomas with really, really good results. So it'll be interesting to see how this performs in a randomized kind of setting versus doxorubicin. And I hope that, they maybe consider doing it in combination with dacarbazine, because that really is an active combination. I really second the fact that doing surgery for these patients after you've gotten response from chemo and you've demonstrated stability of disease is really a powerful tool to have. I've often pushed patients with this disease to go to surgery, even though the surgery may be kind of extensive. But if you've gotten good control with the chemotherapy and you've maybe, sterilized the margins with some radiation, then the surgery really makes a lot of sense. And this study kind of highlights that, even though that wasn't their main intention, but I think that was a very good inclusion for them. So I'm excited to see more of this combination. I'd love to see kind of more robust data in a randomized fashion. That will happen some years in the future. But I think this is a very promising combination.
Yeah, and I think that study is actually already ongoing, right? I think the LMS-04 trial is the randomized phase 3 study that's comparing trabectedin, plus dox versus dox alone as first-line therapy in metastatic LMS. Again, I totally agree with you. I think that'll be, hopefully, kind of the next big real practice-changing, study for these individuals with this condition. But I totally agree with you. I think to me, one of the most impressive, take-home points I was highlighted was, again, the importance of multidisciplinary care of these individuals, and the sheer fact that even these individuals who have very advanced disease to get on the study, if you can get them to surgery, right, and have kind of a highly skilled surgeon operate on them, well, you could potentially get these individuals into a remission.
Yeah. Thank you for highlighting that, by the way. I mean, I think we need to keep plugging the fact that sarcomas are a complicated disease that really needs multidisciplinary specialized care that sometimes the community isn't able to deliver. So if you have a sarcoma, please refer early and refer often to a specialized cancer center. They might be able to go on a clinical trial like this one that may really make a difference for them.
Yeah, no, Roman, I second that. And, I know multidisciplinary care is really a focus of how we take care of the individuals here. Every single individual with sarcoma that we take care of has gone through our multidisciplinary conference where we have our radiation oncologists, orthopedic oncologists and surgical oncologists, our other medical oncologists, radiologists, pathologists involved. And that's been, I think, pretty critical to them receiving the best care possible. So, Roman, thanks so much for joining me on this podcast. I think this was a lot of fun to go through this exciting data from ASCO. There were just so many trials. There's so many more I would love to talk about, and really enjoyed it.
And thank you for having me. I had a lot of fun discussing all this great data. Thank you, everybody, for listening, and have a great day.
That's all we have for today. Thank you for listening to OncLiveOnAir. Check back on Mondays and Thursdays for exclusive interviews with leading experts in the oncology field and recaps from our State of the Science Summits and institutional perspectives on cancer webinars. For more updates in oncology, be sure to visit www.onclive.com and sign up for our e-newsletters. OncLive is also on social media. On Twitter, follow us at OncLive and OncLiveSOSS. On Facebook, like us at OncLive and OncLive State of the Science Summit, and follow our OncLive page on LinkedIn. If you liked today's episode of OncLive on Air, please consider subscribing to our podcast on Apple Podcasts so you get a notification every time a new episode is posted. While you are there, please take a moment to rate us. Thanks again for listening to OncLive on Air.